Good morning. This is Kim Kinnaird with Cornerstone. Thank you for joining us today for the group corner with UnitedHealthcare and OptumRx. I think they've got a really interesting presentation they're going to do for us. Just a few housekeeping items before we get started. If you've got a question, there's a question box. I'll monitor that. We'll answer questions at the end of the presentation. There's going to be a short intro with some brief updates from UnitedHealthcare sales folks from around the state, and then we're going to get into the meat of the presentation. That's me. I don't know why I should put that in there, and you don't need to see me. There's a couple of different things that on this slide to talk about that Cornerstone can help you grow your business. You pilot your business and we'll be your flight crew. Just briefly, we've got the autopilot, which is a client referral program, where if there's a segment of health insurance that you're not doing or interested in doing, you can send referrals in and we'll pay you for those referrals when cases get sold. Parachute is for succession planning. So if you don't have a family member or someone who can pick up for you if something dreadful happens, Parachute is there to help. We'll draw up a contract for you. It just kind of helps you establish your estate. It doesn't prevent you from, selling your business or doing something different if your plans change, but it does provide you something right now. And another good thing is, you can tell your clients you have a plan if something happens to you, especially if you're a smaller shop. Flight plan is for folks getting ready to retire. We can kind of help you structure your business so that you can slowly wind down or get out of it right away. There's all different scenarios that work for different people. And co-pilot is a service agreement. So we can do from soup to nuts behind the scenes to support your business. If you're a really good salesperson and you don't like doing spreadsheets and you don't like answering the phone or doing service stuff, you can hire us and we'll do that for you. Or if you like doing that stuff and you don't like doing other parts, spreadsheets or, all kinds of different things. So just talk to your Cornerstone rep and maybe we can build a plan for you. You can learn more at the agency services program link below. And then the other exciting announcement is this partnership with EB3, which is an employee benefit booklet template tool. You can build SPDs and wrap documents. You can add to your own PDF documents, with us all being virtual, much more virtual than we've been in the past. You can build a benefit booklet that can be emailed out to employees. It has all their open enrollment materials. And when I say pop doc, that's that premium conversion plan that a lot of groups don't have. You can set yourself apart by actually preparing the SPD for your groups. It's a really great tool. I suggest you look into it. And with that, I'm going to turn it over to Rick Sudetic and the team at UnitedHealthcare. So just bear with me while I do that. I'm going to make Rick the presenter.
Great. Good morning, Thanks, everybody. Can you see my screen?
We can.
Yes.
All right, excellent.
Good, Rick.
Thank you. Awesome. So thank you, everybody, for getting together today to learn a little bit more about UnitedHealthcare and in particular OptumRx. Our key presenter today is Kevin Kittrell from OptumRx. He's the Vice President of Sales, and he supports the UHC sales team on our sales opportunities for you. So I'm okay. On the phone today, we have many members of the team that supports Cornerstone statewide in both small business, in key accounts 51 plus, on the ancillary benefit side, and then, as I mentioned, Kevin's joining us today. So I just want to call out, Christian Batts and myself handle 51 plus sales. Christian's downstate. I handle things up north for 51 plus. In 2 to 50, we have Ed Lightcalf in Cleveland. Yeah, Ed handles Cleveland. Ray is down in Central Ohio. They were unable to join us today, but Donna's going to give us an update on our MIWA, and Whitney's going to cover off on All Savers before we begin the OptumRx presentation. And Christian and I have a couple updates for 51 plus for you. And then our ancillary team is Rachel Finn, Mark Milos. They both handle 51 to 99. And then Joe Gilmore handles 100 plus business. So here with the updates. First, again, UnitedHealthcare is all about putting the customer at the center of everything that we do, and it's really about supporting them and their employees by activating and engaging their employees. We have this 4P wheel where we believe that people are a group's most important assets, and their productivity determines their performance and ultimately the profitability and bottom line of the organization. And our role is not just as a health insurer, but really as a health plan to bring health improvement and activation and engagement, resources, tools, and support for those employees so that they can be more productive. That ultimately leads to a better bottom line. So UHC is about making people live healthier lives and making the healthcare system work better for everybody. And I think today's conversation with Kevin on OptumRx and how we've built a synchronized, integrated model really does make healthcare work simpler, particularly with regards to integration of pharmacy into the medical plan. And here in Ohio, we have a belief that if you improve your health, you improve your life. And we put a lot of investment into health improvement initiatives like Motion and Real Appeal and Rally and things like that. So we put our money where our mouth is. So with that, I'm going to flip it over to Donna, who's going to talk about the small business MEWA update for Ohio for 2 to 50 groups. Donna? Donna, you might have us on mute.
Okay, I'm sorry. This is Donna Hesselbeck, and I am a UnitedHealthcare sales rep in Southwest Ohio. And today I'm going to talk to you a little bit about the MEWA. But I want to just mention first that with UHC's 2 to 50 small business product portfolio, you have 3 viable options for your employer groups. We offer the ACA fully insured products. We have All Savers level funded product that Whitney's going to talk to you about. And then the MEWA, which is backed by the Ohio Chamber of Commerce. And I'm going to focus on that right now and give you a few updates. I always want to remind people that the MEWA has a common renewal date of January the 1st. And one of the unique features, I think, compared to the competition is groups can offer an unlimited number of plans with no additional load to the rates. And the MEWA is packed with the value adds that you're familiar with, like Motion, which is available on the HSAs. And Motion actually is a walking program that rewards employees and a covered spouse. They track their steps with a Fitbit type device, and they each can earn up to $1,095 annually. And to tell you the truth, it was not me that messed up in the middle or in the beginning of the presentation, because I was actually standing up, getting my steps in place. So it wasn't me that touched the computer. So I do Motion. That's my favorite program that United has. And it's easy to do. And as a Cornerstone broker, I would encourage you to reach out to a rep if you have any questions on any of these programs we talk about, because we can give you some more in-depth knowledge. Another value add that you're familiar with is Real Appeal, which is a 52-week web-based weight loss program that provides employees with a support system that helps them lose weight and engage in healthier lifestyles. The MEWA also includes Quit for Life, which is the smoking cessation program, Rally Health and Wellness, and free virtual visits on most of our non-HSA plans. Also, the MEWA access fee is $7.50 per employee per month, and that's going to be billed on the UHC invoice, and it's going to be indicated on your quote as estimated association management fee. So that's the fee that the chamber charges. We also have ancillary plans that can be sold with the MEWA offering. I just want to mention that package savings does not apply, but we have discounted the ancillary rates on the dental, vision, and life. We always want to try to package ancillary anytime we sell the medical, just because we feel it's a good fit when we can help members with that integrated financial protection. All of the MEWA groups are COBRA eligible, and COBRA is automatically set up with UnitedHealthcare Benefit Services. The other thing I want to mention is the broker commissions are $30 PEPM regardless of group size. Now on ACA, that's not the case, but all of our MEWA products are $30 PEPM. In addition, the dental, vision, and life is a % of premium, and the ancillary sales do accumulate towards the broker specialty bonus. See, there are a few MEWA requirements to join. You have to join the group has to join the chamber, and the fee ranges anywhere from $150 up to $650, and it's based on the number of employees that actually enroll. Another requirement is the groups must be located in Ohio, and the majority of the employees enrolling must reside in Ohio. One other thing, when you're requesting a quote for the 2 to 50 size groups, I always recommend that you quote the MEWA and All Savers, simply because sometimes the All Savers product can be more competitive than the MEWA. So we always suggest that you request both, and the applications for MEWA and All Savers are on FormFire. So it's easy to go in there, download the MEWA app and the All Savers app, and request a quote for both. And then by showing both options, your employer groups have more choices with UnitedHealthcare. At this time, I'll turn it over to Whitney, and she can talk about All Savers for you.
Awesome. Thanks, Donna. Hello, everyone. My name is Whitney Winters. I'm the Small Business Account Executive for the Greater Toledo, Ohio area. Happy to be on the call today. I'm going to give a high-level overview on our level funded solution known as All Savers. Recent update that we made to All Savers is that it is now a product that may be quoted for groups 5 up to 300 lives. So we have now expanded the product to larger size groups because of how great of a product solution this is. With All Savers, there is an option for 12 or 15-month rates for the group. The 15-month rate option is a great option for groups, and it's offered for 11/1 to 1/1/22 effective dates. Something else to note on All Savers is any number of plans may be sold to a group, just like the MEWA solution that Donna was discussing. Again, that's definitely something that separates us from the competition. Then probably one of the best parts of All Savers is the surplus refund if groups perform well on the product. Something to keep in mind is that in Ohio, it is a 50% surplus refund, and this does vary state to state. So please contact your account executive if you have questions on a group in another state. A quick stat that I'd like to share on the surplus refund is data from April 2020 through March 2021 showed the average surplus refund in Ohio was $6,100, and 26.5% of groups actually received a refund. Then in regard to the value adds that Donna touched on, something I like to point out, actually Donna taught me this, easy way to remember, with All Savers, you get it all. And by that meaning you receive all of the robust value added solutions on all of the plans with All Savers. So Motion, our program for earning financial rewards for walking, is available on all plans, as well as Reappeal, which is our lifestyle management solution. That's available on all plans at no additional cost as well. Then with virtual visits, those are something many members are interested in these days, making their lives easier, being able to have doctor visits at home. The virtual visits provider for All Savers is called Healthiest You. And something great to note here is that with All Savers, virtual visits are not billed as a claim. So employers definitely want to push their employees to utilize virtual visits as much as possible, because this can also help the group obtain the surplus refund at the end of the year since they're not being billed as a claim. Then with the specialty products, we do offer package savings program, which can save up to $7 per employee per month. If you'd like to learn a little bit more on details for that program, feel free to reach out to Don or I, and we can send you over a flyer listing some of the details on how a group is able to qualify for the program. And then I did want to point out that groups of 20 plus eligible employees do qualify for COBRA through United Benefit Services with All Savers. So just keep in mind with All Savers, it's a little bit different than the MIWA. You do have to have 20 employees and up. And then lastly, we do have some product updates and changes coming for 9/1 effective dates for All Savers. So I wanted to make sure to let all of you know to look out for an invite that just came out from all of us for a webinar on June 29th at 9:30 a.m. or 2:30 p.m. We have 2 sessions going on, so make sure to join one of those so you hear about our updates. And in conclusion, both MIWA and All Savers are great options for your small groups. As Donna said, make sure to quote both products on every group possible and reach out to us if you have any questions. I'll pass it over to Joe if he made it on the line for a update on Benefit Ally.
Yeah, I don't believe Joe is on, so this is Rick. I'll handle this, and we have Rachel Finn and Mark Milos from our specialty sales area, and they concentrate on 51 to 99. And right now, they offer a full spectrum of supplemental health programs. These are, voluntary critical illness, accident protection plans, and hospital indemnity plans, which actually marry very well with high deductible health plans to kind of mitigate the members' exposure to healthcare costs and cost share within the health plan. What we've done for our key accounts is just launched, and this is becoming available October 1st, is a packaging of those supplemental health programs into a program we're calling Benefit Ally. And this will be included in our fully insured medical programs, again, for groups over 100 plus. And this component of the program, the Benefit Ally, will pay a commission of 10%, but it's bringing all 3 programs together, accident protection, critical illness, and hospital indemnity. It's approximately a $5 to $8 load. There's 2 levels of benefits. There's a value plan, there's an enhanced benefit plan, but it's very packaged. And like I said, we're going to be incorporating this into our medical plan offerings. And there's no pre-existing condition exclusions with these products. And the best part is that the claims streamline, that when we identify somebody that has a medical claim and could be eligible for any one of these sub-health programs, the claims processing is streamlined. So we're kind of using data mining for this. So it makes the member experience very good when it comes to claim time, that we're going to make them aware of a benefit that they may not even have had. So we're really excited about the launch here of Benefit Ally. All right, with that, I'm going to flip it to Christian, who's going to talk about Bind on Demand.
Yeah, thanks, Rick. Just a quick hitter on Bind. So Bind, we've done a presentation on Bind. Just one big thing to note is we have been approved, and Kim, to kind of steal something from your earlier slide, we're go for launch with Bind in the state of Ohio for 51 plus fully insured. Again, that's 51 plus enrolled lives that we are ready to quote. We are quote ready for in the state of Ohio. From a self-funded standpoint, we're looking for 125 enrolled lives. And again, Rick's flashing up a couple things here. Bind, again, we had Pat on the call, one of these earlier calls, and he walked through the plan. Bind just kind of reverse engineers how we purchase healthcare, and it's really app driven, and you can see that up at the top right there. Within the app, there's basically a search bar, and you search for just anything, a doctor, a procedure, a prescription, and the Bind is going to show you based on your geographic location, where you can get that prescription, see that physician, get that procedure done around your area, and what the cost is. There's no co-insurance, there's no deductible, it's a copay plan, and everything just rolls to an out-of-pocket max. We've had a lot of traction with it in the state of Ohio. It continues to gain even more traction. We're doing a ton of NOAS meetings with clients because it is just kind of a new concept, and that would be our ask. We're not going to just, we'd prefer not to just shotgun these quotes out. We want to be targeted with our approach. It's certainly a door opener for you as agents to talk to your clients about, because it is really a game changer and something very unique in the marketplace that we can offer. So you can see some of the stats there. I won't go through everything, and I want to be respectful of Kevin's time because he's really the crux of this presentation. But overall, like Bind definitely lowers the cost of healthcare within the plan. You can see there, on average, out-of-pocket max is $448 versus $943. And then from a satisfaction standpoint, in the bottom right, when people have replaced their previous plan with a Bind plan, 74% prefer that plan. And their NPS scores, the Net Promoter Scores, are through the roof relative to what the average is in the insurance industry. So again, just kind of a quick overview on that. But again, we are ready to roll for 51 plus fully insured. And again, on a self-funded basis, it's 125 enrolled. Reach out to Rick and I if you have a group that might be interested in it. And again, we can talk through it. We can get one of our Bind contacts on the line to chat with the group as well. But we have a quick demo that we can go through, 20-30 minutes, that just walks them through what they would see as employers and what their members would see and feel if they were to go with a Bind plan. So, Rick.
All right, great. Hey, thanks, Christian. And kind of along the same theme of with Bind and Christian, describing this as a game changer. I think this just demonstrates what an innovator that UnitedHealthcare is in bringing new and different products out to the market for you guys to deploy for your customers. And another area that's, again, I would view this as a game changer is how we're addressing the problem of diabetes in our society. And we know that diabetes prevalence is just off the charts. It's doubled since 2000. There are over 80,000 deaths a year. And when we do analytics with the customer in reviewing their plans, in nearly every case, diabetes and its related complications are in the top 5 of spend driver for our customers. So if you look at our population, probably 5 to 6% of the population has type 2 diabetes, and that's what level 2 was designed for. We started with this in our Medicare population in an approach to support type 2 diabetics with kind of a heightened attention to their care. The type 1 diabetics have a pretty aggressive care path with an endocrinologist, whereas type 2 diabetics typically see a PCP maybe once a quarter and get their A1C measured or the glucose tested. But diabetes, or with level 2, what we're doing is we're continuously monitoring those diabetic patients by issuing them a continuous glucose monitor. We're giving them a Dexcom G6. It's a Band-Aid size application that really has telemetry that attaches to their abdomen and gives readings every 5 minutes that are fed in through a phone app, through the internet, and monitored by the level 2 care team. And level 2 is more than just a health coach. These are nurses, doctors, PCPs that are monitoring the care and activities of the type 2 diabetics. And this has been phenomenally successful in our Medicare pilot. And then we launched this across 27 different states in our fully insured portfolio. And Ohio was the first to get level 2 included automatically into our plans. And in addition to the Dexcom G6 glucose monitor, we also issue a motion tracker device, and they get rewards for walking. And it leverages machine technology so that by monitoring the glucose, if we see spikes, the member would get a text, an email, an outreach call from an advocate at level 2 that, hey, maybe it's a good idea, your A1C spiking, go take a walk. It's after dinner, instead of sitting on the couch watching TV, take a walk. And it's marvelous how the results improved A1C levels for these patients. So it's in fully insured today, and now we're launching level 2 for self-funding. And this is a different approach because it's not a plug and play program, but rather a marketplace approach where we set up a separate carve out self-funded plan for the level 2 members. Those that have type 2 diabetes and their family members would be carved into a separate plan with similar benefit features as the underlying population, but enhancements such as waiving the deductible if the member is wearing the continuous glucose monitor, and giving them $0 copay for the glucose monitor, for a diabetes drug package, for an endocrinologist visit, all those types of enhancements to the plan. And we're putting guarantees around this. So this is available for groups that are with UMR or UHC ASO. So it's for groups of 250 or more, and we put a guarantee on their trend, 2% in the first year, 5% in the second year, and 8% in the third year. And if there's savings through this chassis, that's a split back to the self-funded plan sponsors. So it's a very accountable care delivery approach toward putting type 2 diabetics into remission. So talk to Christian or myself if you have an interested customer. This is right now on the larger side of the self-funded spectrum, 250 or plus, but know that all of these benefits here are in our fully insured plan as well, automatically. All right, with that, that concludes our updates for UnitedHealthcare. We're going to flip it over to Kevin Kittrell from OptumRx to talk about the value of pharmacy integration and UHC's approach to an optimized pharmacy strategy, and how we set our PDLs and our clinical programs and our pharmacy networks. So Kevin, thanks for supporting us today. I'll pass the baton to you, and I'll run the slides for you.
All right, thanks, Rick. Appreciate it. Again, Kevin Kittrell. I'm with OptumRx, so I support state of Ohio for needs for pharmacy related. Appreciate everyone's time today. You can go to the next slide. When we look at, when we pivot to pharmacy here, a lot of times it is the #1 utilized benefit on a health plan, and it's also coming with some financial challenges. If we went back just 10 years ago, pharmacy costs probably related to about 20%, maybe less, of overall cost on a health plan. With the advent of specialty, costs on the pharmacy side really have increased, and we're upwards of 35%, maybe 50% of costs on a health plan. So really, really important in terms of the cost of pharmacy, what's happening with pharmacy, the drugs that are coming to market. And historically, you've seen a lot of fragmentation in the pharmacy benefit management area, where medical was working on one side and pharmacy was working on another and not really talking to each other. And Rick mentioned it up front. This is our integrated pharmacy with medical management model that UnitedHealthcare has created, where we're creating the model where pharmacy and medical are talking together, and we're able to do a lot of things with that. And on the slide here, you can see on the far left, empowering physicians. We're giving our providers that we have in this great network that UnitedHealthcare has developed the ability to see into the formulary, and I'll talk about this a little bit later in the presentation, so we can give physicians information to make them, more adept at, managing costs for their patients and our clients. We're also using pharmacy data to synchronize engagement. One neat thing about pharmacy is, as soon as a script is filled at the counter at Walmart, it becomes live in our system. So our clinicians and the care management team can see that data. They're able to do that when somebody calls in the customer service. They can see that, Rick just talked about a diabetic, maybe a newly diagnosed diabetic has just filled the script, and we're able to use our Advocate for Me people to do things with that data. In the middle, you'll see partnering with retail. We've got a lot of options with our retail providers where we can do some things around retail 90 offerings. We're going to talk about our network where we can partner with retail to do things with our network to get more aggressive pricing for our clients. And then finally, innovating with pharma, moving to value-based contracting. You hear it on the medical side, we're rolling it out on the pharmacy side. You know, if we've got a high dollar specialty drug with a big price tag, we want to make sure we get a return on investment for our clients for that. So we're doing value-based contracting for pharma to say, okay, you said this drug is going to cure hepatitis. We want to see the statistics and be able to contract on that basis and pay for that drug on the basis of what we're getting there. So Rick, you can go to the next slide. So really connecting medical and pharmacy on this slide here, we're showing all the different areas where, you know, we touch it on the pharmacy side, be it on the right side in the middle there, you see our advocate for me. I mentioned that a minute ago, very important to us because when you look at 85% of first call to our customer service unit, it's around pharmacy. So when they call into us, it's usually a question around pharmacy or a question around maybe they need a lower cost alternative or something around home delivery. And our advocate for me people, when they take those calls, can do a lot of things with that. They can take that newly diagnosed diabetic and engage them in a disease management program. So connect them with a nurse that can start working with them on that diabetic, condition. So that gives us a lot of ability to, integrate, and it drives medical savings. In the middle there, you'll see up to $25 per member per month medical savings. And we generate that by having our nurses and the care management team avoid those costly emergency room visits, inpatient stays. So if they can, engage with our members, it can really drive down costs on the medical side. And you'll see some of the other things in here, pre-check my script, which I'm going to talk about in a minute, our hospital discharge program, which I'll talk about in a minute. So just a little preview of some of the things we've got in the presentation here to give you of the touch points that pharmacy and medical have together. So Rick, you can go to the next slide. So on the power of integration, this gives a perfect example of what happens with a traditional PBM versus when we have an integrated model of what we use with OptumRx and UnitedHealthcare. A traditional PBM model that is not integrated, just runs claims, they're filling scripts. That's what you think about with pharmacy traditionally, just script comes in, the PBM fills it, goes to the member, but the data doesn't flow through to the medical side effectively. What happens is they just drop it down once a month. So that claim data is very dated for the clinicians on the medical side. With our integrated model with OptumRx and UnitedHealthcare, we get real-time claim data, and that's really powerful. If you think about 10% of all inpatient admits are due to medication adherence issues. Somebody's not taking their medication, or a perfect example is a diabetic. They're not taking their medication. If they don't take their medication, bad things happen. They have to go into the hospital. So all of a sudden you got a big whopper claim on the medical side. So if our clinicians can see what's happening, and we have an engine run by OptumIQ that can kind of look at what we call them gaps in care. Somebody's not taking a medication, or somebody's just been discharged from the hospital on a hip surgery, hip replacement. We normally see a blood thinner. We're not seeing it. So we pop up those little alerts to our nurses so they can do outbound reach to our members to say, hey, what's going on here? I'm not seeing the drug. And it lets us reduce medical costs by closing those gaps in care. So again, you can see once we have real-time claim data, we have a 60% more likelihood to engage in case management programs. So we can connect our nurses with a much more robust information. And it's really why you're seeing the market move to an integrated model. You've seen Aetna and CVS combine, you've seen Cigna and ESI combine. It's really because of the power of pharmacy data and what pharmacy data can do in terms of reducing medical costs. So it's very, very powerful to have the integrated model to drive down costs, mainly on the medical side. So Rick, you can go to the next slide. So prescription drug lists, here we're showing on the fully insured side, the self-funded side for UnitedHealthcare, the self-funded side for UMR, all the various drug lists we have available depending on what channel that client is in. And we've got prescription drug lists that have the ability to drive down costs. They're a little more restrictive, so they increase disruption a little bit. And really when a prospect comes in, a Rick, a Christian is the one who picks what list they decide to go with, depending on maybe a conversation with you. And Rick, I'll let you maybe mention a couple comments about what you like to look for when you're picking what drug list we're going with.
Yep. Well, I think on the self-funded side, we're leading with the flex-based PDL because employers are looking for cost-effective ways to manage their overall spend, and flex-based just brings a fantastic financial value proposition to the table with a great mix of sharing of rebates through UnitedHealthcare, which we have a lucrative arrangement, and it has a hybrid approach where we're giving a fee credit for the rebates, and then we're sharing rebates on a guaranteed basis quarterly. So it's kind of the best of both worlds. So nearly all self-funded proposals I'm putting out on the ASO platform is flex-based PDL, and the other side of that equation is the number of exclusions. In order to drive some of those rebates, we do have vigilant exclusions where there's always an alternative available. So if somebody's looking for something more liberal, we can go to a traditional PDL model, but for the most part, flex-based is my lead.
Okay, we go to the next slide. So the next slide, we talk a little bit about our Advantage and Essential PDL formularies on the fully insured side, and really some of the differences of what we see in Advantage PDL on the left there. You can see, we have medications that are excluded. On the right, you can see with Essential, what we do with Essential is we have a more narrow formulary offering. So we've got non-covered drugs. We refer to them as non-formulary. They're not going to be covered frontline, but there is a pathway to them because we've narrowed the formulary down. In certain cases, a member maybe can't take what is on our formulary. So we give them a pathway to the drug. So it's a little narrower offering. On Advantage, we can use a 3-tier or a 4-tier. With Essential, we are using a 4-tier PDL or formulary offering, and with some pretty significant copay on the tier 3 or 4. So we're really trying to drive members to those lower cost alternatives in tiers 1 and 2, because that's how we're trying to manage more aggressively on the Essential PDL. Generics can be in any tier on our formularies simply because you think of generics, you think of low cost, but that's not always the case. Certain generics, when they first go generic, sometimes there's only one manufacturer. The cost break is not there yet until we get multiple manufacturing driving down generics. And then really the big difference on Essential is we have multiple exclusions. So it's, again, a narrower offering, and the trade-off is a lower cost point on that. So we have, for anything we always have excluded, even on Essential or Advantage, there's always an alternative. So a good offering there. But again, just a more managed formulary with the Essential PDL.
And our role here, Kevin, really is to deliver a competitive price point as you're setting strategies with your customers. And we're now leading with the Essential PDL on both our fully insured portfolio as well as all savers. And I think when you're looking at copay-based plans, PPO plans, the impact on the Essential PDL is upwards of 5 points. Whereas on a high deductible plan, it's going to be a little bit less because of the impact of that upfront deductible. It's probably in the order of 2%, but it just makes sense from the standpoint of coming to the table with a more budgetable health plan cost for our plan sponsors.
So next we talk about our network. When you think about pharmacy, we have a retail network of all of our, retail providers, similar to what you see on the medical side with, your hospital and provider network. We have the same thing on the pharmacy side, and our standard select network is what we're starting to lead with our clients, where we can offer a little more value to our clients. And what we do with it, we have over 50,000 pharmacies nationwide, so a very deep offering. And we're using Walgreens as our anchor retail network. So CVS is not in our standard select network. We do have offerings to get them in there if that's a big showstopper, but this gives us ability to give us more discount, similar to what you see on the medical side. If you've got 2 hospitals in town, if you contract with one, you get a deeper discount. Very similar with our standard select network. So we contract with Walgreens to get deeper discounts with Walgreens to help drive down our costs for our customers. So it still gives us very, very strong access. So if you look at disruption, really within our urban members, within 2 miles, we have 98% of access within 2 miles. And then if you go to 5 miles, it jumps to 99%. So really tremendous access for our clients, even on the standard select network, which is why, again, we have this offering to really crunch down costs in terms of what we can offer with very, very minimal disruption to our clients.
Yep. And similar to the essential PDL, the standard select network is now our default offering on both fully insured as well as the All Savers portfolio.
So next, turning to specialty medication. This is the #1 concern for our clients because of the cost pressure specialty medication is putting on the pharmacy side of the house. Specialty does amazing things. It can cure hepatitis. There's a version that can cure a form of blindness. So it does amazing things, but it comes with a huge price tag. So it's putting a lot of pressure on the pharmacy side. And you can see in the graph here, there's 188 specialty drugs in the pipeline for potential approvals by 2021 this year. That's a lot of specialty drugs in the pipeline. And we break it out at the bottom. You can see how many go through the pharmacy benefit. And specialty is a little different because it can go through the medical benefit. Sometimes specialty is infused in a doctor's office. It's actually billed through the medical side. So it goes through our Choice Plus discounts. So we look at specialty a little different because it doesn't all flow through the pharmacy side. And really on the far right there, you can see oncology on the medical benefit of what's in the pipeline. 29 drugs are in the pharmacy side, 23 are going to be on the medical side. So about not quite 50-50, but pretty close. And on the far right there, you can see oncology is the highest area of specialty drug spending right now, and you can see what's in the pipeline, 50 cancer drugs in the pipeline by the end of 2021. So a lot of activity in specialty. So we're really managing the pipeline and looking at these drugs and looking at when we expect the approvals to happen, what we expect to do with them. We're going to put them on the medical side, or we're going to put them on the pharmacy side. What clinical programs are we going to attach to those? So there's a lot of activity in specialty, and unfortunately, a lot in the pipeline. I mean, we expect that those oncology drugs to do, again, amazing things, but we also expect them to have those high price tags, so that we're trying to manage that as effectively as possible. So if we go to the next slide, we really talk about, how we manage specialty. So especially I talk about the costs we have with specialty, but we want to look at, how does UnitedHealthcare manage specialty? What do we do about it? We're looking here, 55% of specialties on the pharmacy side, 45% on the medical side. And we talk about some of the top classes. Inflammatory is another one. Oncology I talked about. But there's a lot of things we can do with specialty. #1 on the list here, you can see site of care. A lot of times we have site of care programs to where we're looking at, if we have somebody in a hospital setting Can we move them to a lower cost of care? Can we move them to a home health care? Can we move them outpatient? So that is a big cost saving area to where we will, look at, we do that a lot of that through prior authorization to say, hey, as we're prior authoring, something, our nurses are looking to, step down care when appropriate. Sometimes it's not appropriate. So, but if we can move them to a lower level of care, you can see, 43 to 55% shift to a lower cost setting. So there's a lot of ability to move to lower costs of care. Another area, number 2, is our specialty in our cancer guidance programs. We've developed platforms where our providers go to prior auth things. We have a little module they go through, and we help with the cancer guidelines, triage them to the most appropriate care for them to give. So they're not using experimental situations that are going to get declined or not approved. And we've seen 99% of cancer patients begin on the right therapy through our auto decisioning tool. So we're giving our providers tools on cancer guidance and specialty to try to get them to the right area, just to make sure that they have all the tools they need so that we can have a successful first fill. And we're gonna, again, not getting something experimental or not getting something that, we have to say that treatment didn't work and throw away that treatment and let's buy another treatment. So again, just a more efficient model. And finally, biosimilar management. Biosimilars are kind of the generic version of a specialty medication, to where we're trying to say, okay, there's biosimilars. Probably 3-5 years ago, there weren't a lot in the market. They're starting to become more prevalent. In another, I think, a year or two, we're going to see some on the inflammatory space become available. And there's a 35 to 40% savings opportunity with biosimilars. So the more we can, try to get them more prevalent, get them on our formularies, drive to them as a strategy, we can see some savings on the specialty side. So next is our medication adherence slide, where we're talking about, I mentioned earlier, 10% of inpatient admits due to medication adherence issues. So the more we can focus on levers that, can affect, how do we keep people out of the hospital? How can we keep them more adherent? The more we can, affect medical costs. And two of the programs on this slide here are expiring PA program at the top, and at the bottom right, our diagnosis to script program. Our expiring PA program is when we have a expiring prior authorization, we do some outbound reach to the provider. 66% of rejects at the pharmacy are because of prior authorization is not on file. So the more we can reduce that, the more we can have two things: a better member experience when our members go to pick up the pharmacy at the retail counter, and just a less hassle factor overall, and more adherent members to taking their medication. So we don't have somebody not taking a medicine and maybe over the weekend they have to go to the ER room and be admitted to the hospital simply because they didn't have their medication. The other program is our medical diagnosis script. The nice thing about our integrated model is we have medical claim data, so we're able to use that to satisfy the prior authorization. So we can reduce the prior authorizations by 40% just because we have the medical information on file. So if we see someone who's, asthmatic and we've already got that medical claim, we don't need the prior authorization. We just fill the script because we know they're asthmatic. No need to reach out to their doctor. So a lot of programs there. And finally, I'll mention just on this slide, our pre-check my script tool, which I'm going to talk about next, is our innovative tool to help give our providers visibility into the formulary. Rick, you can go ahead and move to the next slide that talks about pre-check my script. Rick mentioned it earlier. We're one of the innovators when it comes to, looking at things on the medical and pharmacy space of, breakthroughs that can really drive change in the healthcare space. And Project My Script is a tool we developed for our providers. And if you think about a provider seeing 20, 25 patients a day, they're with multiple carriers, multiple TPAs, multiple different PBMs. They don't know all the formularies. So we've developed this tool when a provider's in our maybe in the electronic medical record, they're prescribing a drug, sending it to Walmart, and they said send. We pop up a little box to show the provider what lower cost alternatives are on the member-specific formulary with us. So we're showing them lower cost alternatives, and under the better outcomes on this slide here, you can see 80% of tier 3 drugs that are being prescribed are being shifted to lower cost alternatives. When we do that, when the provider does that, it gives a lot of cost savings that you can see over the left. We're saving consumers $225 per script. We're saving our clients $415 per script. We're saving our physicians $41 since the administrative burden of avoiding the prior authorization, because this tool also allows them to start the prior auth within the tool. So it has a lot of ability to really drive down costs on the pharmacy side. And we're also piloting this with retail, so that when somebody goes to retail to pick up a script and they maybe have some sticker shock about, oh my gosh, my drug costs what? The retail can see what lower cost alternatives and work with providers to move to those lower cost alternatives, and also we give our members the same tools with our digital tools so they can see lower cost alternatives. So really attacking it from 3 different areas here. So we go to the next slide. Next, we talk about our hospital discharge. This is a perfect highlight of medical and pharmacy working together. We've got an example here of Mary living with cancer and diabetes. She's been hospitalized. She's getting discharged. We've got a nurse on the medical side that's working with her discharge planning. She notices that, we've got a specialty medication. So the nurse reaches out to the pharmacist on the OptumRx side and, kind of gives the pharmacist overview of her situation. It gives our pharmacist the ability to talk with Mary about this new script, talk about her discharge summary, talk about maybe this, specialty medications have to be sometimes refrigerated. They're very special, so it's not a normal drug that you'd see in a pill format. Some of them have to be injected, so there's a lot different with specialty, and this is a perfect example of medical and pharmacy talking together, because normally if you didn't have this integration, the case manager on the medical side would just close out the case, been discharged, and our pharmacist would know that a drug's being filled until it came in house. So there's a lot of ability here to make sure we're filling the drug for the patient, and everybody has an opportunity to look at what's happening, and ability to maybe shift site of care if possible. So if they're getting a specialty drug and it's being on the hospital setting, which is the most expensive, maybe we can shift it to a lower level of care if possible. So you can go to the next slide. Next slide is our innovation, recently launched programs. I talked a little bit about our cancer guidance program, and really we spend a lot annually. You'll see $3 billion annually in technology and innovation costs, trying to find a better way to make the health system work for our clients and our members. And our cancer guidance and our specialty guidance that I touched on are 2 perfect examples of that. Our variable copay program is a program we rolled out last year in terms of specialty medication, where pharma gives coupon dollars, and we're trying to make sure we maximize those dollars to drive down costs on the specialty side as much as possible. So those are 2 programs that you see on this slide here. And Rick, you can go to the next slide. So some of our ongoing investments and upcoming launches. Gene therapy is super expensive. Gene therapy, where they go in, they extract cells from a patient, they re-engineer it and inject it back, and it's not super prevalent, but when it happens to a client, super expensive. So we've got some solutions that we're doing for our ASO clients that can kind of prevent some of the costs around that. We also have a multi-source packaging unit. We call it DiviDose, to where if you've got a client with multiple conditions that's taking multiple medications, we have the ability in our network to access DiviDose, where they can kind of package that up and give our clients, little packages, say, here's my, opening today of what I need to take today. So a lot of ability there to, just simplify it overall. And again, just some other things we're doing around behavioral connections and digital notifications, just to give our members more information and make sure that we're giving them, the ability to be more adherent overall, and giving them the ability to, have a better member experience when it comes to pharmacy. So in closing, this talks about, our vision to transform healthcare, really make it, our goal here is to make it, number one, simpler for our employees. We want a good experience when they go through pharmacy. We want them to, have information so they know options. We want to give visibility around costs. So, pre-check my script that I talked about is giving our providers and our pharmacies visibility around costs so that everybody, including our members, with MyScript rewards and can see what's available out there. And then for our employers, we know that pharmacy is putting pressure on the pharmacy side in terms of cost. So looking at solutions to make sure that we're managing pharmacy as aggressive as possible, and given our ability for to drive down side of care advancements and things like that. So we're continuing to drive solutions for our clients to kind of attack that with the goal for lowest net cost. We want a good member experience, we want a lowest net cost, and we want to be the number one in innovation. We want to be bringing innovation to the market because that's what attacks all that. And Rick, I'll turn it back over to you for any last comments.
Sure. Thanks, Kevin. And yeah, appreciate the comprehensive overview of our value proposition on pharmacy integration with OptumRx and UnitedHealthcare. And I also want to thank Kim for coordinating today's call. And so we're at the top of the hour. Appreciate everybody's time and interest today. Before we go, we do have all the folks from UnitedHealthcare still on the line here. If you have any questions about our updates, or if you have any questions for Kevin about OptumRx, we're here to answer those.
Yeah, this is Kim. I looked in the question box, and I do not see any questions for today. I really appreciate you guys taking the time to do this presentation, give us a deeper dive on OptumRx and what you're doing to help keep costs down. I think that translates to smaller premium dollars, and we all like that. That helps us sell, and that helps families be able to continue to afford healthcare. So thanks again to the team at UnitedHealthcare, and thanks for attending today's session.